Good morning, everyone present here. A very warm welcome to all the participants joining us today. I'm Shazia Shabir, your moderator for today's session. It's always wonderful to see such enthusiastic learners joining us week after week, and today's topic is something truly special. We're diving into the area that is often overlooked but incredibly important in clinical practice: non strabismic binocular vision anomalies. By the end of this session, I'm sure all of us will walk away with sharper understanding and better clinical confidence. And to guide us through this topic, we have with us Ms. Nishtha Verma, Assistant Manager, Project Management and Training at Biotech Healthcare. She holds a master's in optometry from Amity and has served as a professor at IIMT for 2 years. Thank you all once again for choosing to spend your Sunday morning learning with us. Now, without taking any more time, let's get started. Ms. Nishtha, the session is all yours.
Thank you so much, Shazia, for introducing me. So, hello everyone. I first of all I thank Neuroptech to give me the opportunity to present in front of you and share my knowledge with you all. So, let's start with the presentation now. I hope you all can see my screen now.
Yes, ma'am, it's visible.
Okay.
Yes, yes.
Thank you. Thank you so much. Okay. So, let's make the session very interactive. So if you all are having any queries, you can tell me. And if you want to add on something, you all are open to add. And let's discuss about non-strabismic binocular vision anomaly now. So any one of you have any idea what today we're gonna discuss in non-strabismic binocular vision anomaly? What actually a non-strabismic binocular vision anomaly is? Any one of you? Okay, no issues. So let's start. So today in this presentation, we will be discussing a very basic to know about binocular vision, what actually a binocular vision is. We will be to know about non-strabismic binocular vision. So in this, we will be knowing in deep about the non-strabismic binocular vision anomalies, and then the classification or the criteria, how we describe that a non-strabismic binocular vision anomaly. So starting with the binocular vision, what it is. So you all know we have two eyes, we have two retinal images. So our brain combines two retinal image to see things singly, perceive its depth, and locate things around us. So basically, binocular vision is nothing but it is the fusion of two retinal images where it combines the two retinal images to see it singly, perceive its depth, and to locate it in our surroundings. So if any disturbance in it, it might cause symptoms like headache, eye strain, fatigue, double vision, watering, ocular pain, astinopia. So these are very common symptoms you have heard in your clinical experience, or whenever you are in clinics, these are some very common symptoms. So it is like when we are in clinics and we are dealing with patients, so we see these symptoms, and there are various reasons why we can hear these symptoms. So so there are various anomalies in the visual system causing related symptoms that diminish one's clarity, comfort, binocularity, and visual performance. So common binocular anomalies are: first is strabismic anomalies, second is non-strabismic ability, third is sensory binocular vision anomaly, and fourth is refractive and anatomical factors. So these, if we categorize binocular vision anomalies, we can categorize it in these four things. So today we're gonna discuss only about non-strabismic anomalies. So what non-strabismic binocular vision anomaly is? It is the condition where both the eyes are aligned but do not work together efficiently, causing symptoms related to poor binocular coordination. So here, whenever you will be seeing the eyes of the patient, you will be seeming like it is normal. There are no misalignments, but still the patient will be having poor binocular coordination symptoms. So unlike strabismus, where in strabismus you can directly see the eyes and you can see the turns, and but the patient might still have difficulty with focusing, eye teaming, and depth perception. Where in strabismus there is visible misalignment and there are symptoms. But in non-strabismic binocular vision anomalies, whenever you will be looking to the eyes, they will be aligned and it will be normal. So what all are the normal this non-strabismic binocular vision dysfunction? This can be categorized where vergence is affected, your accommodation is affected. So these are the anomalies where you can say convergence insufficiency, convergence excess, divergence insufficiency, divergence excess, basic esophoria, basic exophoria, accommodative insufficiency, accommodative excess, accommodative infacility, and fusional vergence dysfunction. So we will be discussing one by one these things. I hope you all have heard about these anomalies. So the diagnosis is really important for these anomalies, would add stress to any operational demand that coordinates between the eyes. So whenever the patient will be using both of the eyes or in normal seeing condition, when two retinal images will be produced and there will be difficulty using it or to perceive it, the brain will be getting very void full signals. So in that cases there will patient will be suffering from many symptoms like headache, or they will be complaining like if we are doing prolonged work, we are exposed with the headache, eye strain, our vision get blurry with the day. So these all are the common symptoms what we do in clinics. If not treated, could develop strabismic symptoms. So if it is not treated, it can be more severe and it can be developed as strabismus, that is squint, and with the development of suppression and loss of stereopsis. Whereas suppression or brain will be indicating like if the images is not clear and the brain is perceiving some confusion, so definitely in long term it will be banning one eyes signal, and hence it will be causing the suppression and the loss of stereopsis. So whenever the patient comes into our clinic, what a basic evaluators do, so they will be taking histories and they will be knowing the symptoms associated with the use of eyes. So we will document the history. Then next step what a clinician do is to check the visual acuity. So if the visual acuity is normal, or either if it is hampered, we do refraction. And if refraction is normal, then eye health is being checked by using various instruments, like if anyone is having ophthalmoscope, slit lamp, torchlight examination. So we do basic eye health workup, and if it comes normal, basically what a normal comprehensive worker do is, if everything is normal, they say you are normal and there is nothing to worry, and you can consult a journal physician for migraine or something. But no, that is wrong. Here we are going wrong in clinicals. This is being lagged. If everything is getting normal, still we have to check their phoria status to evaluate if the person or the individual or the patient is having any non-strabismic binocular vision anomaly. We have to check the phoria status. I hope you all know what is phoria. Hello. Latent squint. Yeah, okay. Yeah, we can say. Okay, I'll be discussing what phoria is. So, whenever we will be checking the phoria, we will having the two condition. Either the phoria will be present, or there will be no significant phoria. So, if in case the phoria is present, what we have to do is We have to investigate the vergence anomalies. So we have to start with the NFVPFP. If there is phoria, then we have to investigate for the vergence anomalies. But if there is no significant phoria present, then what do you think? We should stop the evaluation? No. Here, if the phoria is not present, then we have to start with the accommodative anomalies assessment. So we have to start with the investigations related to accommodation. So this should be a workup whenever we are seeing some comprehensive clinical sheets. It is very basic, where visual acuity, prescription, history taking, everything is included. But I don't think so this phoria status or the NPC, NPA thing is much included. I am not saying that in every clinic, but most of the clinic or most of the people are not practicing this. So here we are lacking. Being an optometrist or the evaluator, we should bring this into our evaluation to make the optometry more into use. So we will be discussing what actually a phoria is. Phoria refers to a latent or the hidden misalignment. As you said, that was true. So phoria, what is phoria? Phoria, it is the hidden misalignment of the eyes that become apparent, or a person can see it when binocular fusion is disrupted. So phoria is something, uh, it is a latent, so it latent means hidden. It is a hidden misalignment when our both eyes are together. It is teamed. You all know there is binocular fusion. So the eyes are aligned, but when this fusion is break using but when this fusion is break using cover and cover or alternate cover test, when we break the fusion, what we will see, our eyes will behave differently. That difference we have to notice whenever we will be doing the cover and cover test. So we can get to know if the eyes are teamed, working together, or there are some misalignments. Those misalignments we have to check. That small misalignment can cause a huge symptoms to a person or the patient. So I hope you all are clear with the phoria, what actually a phoria is. Hello.
Yes, ma'am.
Okay, great. So I want some responses because I am feeling like only I am speaking, but
So,
I want interaction.
Phoria is that particular deviation which is controlled by the fusion.
Basically, it is a misalignment. See, whenever we see our eyes, what do you think a misalignment is? One eye is straight and another eye is turned. In which, if it is tropia, if it is visible, it is squint, it is tropia. But if it is hidden, like we can see a patient's eye is normal, but whenever we break the fusion, then the misalignment comes into play. I will be discussing how it will be. But it is a hidden thing. Like if fusion is present, like in weak condition, diagnose it is a misalignment it is present. So it is hidden. So there are two things basically. One is tropia, one is phoria. Tropia is a visible misalignment. When you can easily see, you have seen squint patients, the misalignment is very prominent. ESO, exo, you can see the eye turns, ESO, exo, hyper, you can see. So that is tropia. And phoria is something when you when the patient is in normal viewing condition, we can't say that the patient is having any misalignment. But when we break the fusion, when we cover another one eye, and patient is fixating from one eye, when we are removing the cover, the covered eye, we have to see the covered eye. The covered eye will be showing the movement. That misalignment I'm talking about, that is the phoria. This phoria can be ESO, exo, hyper, hypo, same as the tropia, but phoria is only visible when we will be breaking the fusion. I hope it's clear now.
clear, ma'am.
Yes, ma'am.
Okay, great. Okay, so checking the phoria status. How we check the phoria status? Patient was suspected binocular vision problem as everything was normal, but when we covered uncovered, so
थोड़ी देर
we
में
will
नहाऊंगा.
perform. So we will perform.
लगता है यही पह रहा हूँ मैं.
Sorry, I want everyone to
अरे
be
यही कह रहा हूँ ना.
switch your
Neeraj
mic off.
Yadav, please mute your mic. Everyone is
फ्रेश फ्रूट
requested
धो
to
दिया एक जोड़ी
please
मेरा.
mute your mic.
Okay.
Yes, ma'am, you can continue.
Okay. Thank you. So basically, now how we can how to check the FORIA status? There are various techniques. So I will be discussing to. Do you know what is cover uncover test and alternate cover test? Anyone can explain what is cover uncover test and the alternate cover test? So it
Take
is
a
a bit.
chance, and please, if
Mhm.
anyone want to answer, go ahead.
Okay, no issues. I will be
Yes,
explaining.
ma'am. With the help of cover and cover test, we can detect phoria, and by alternate cover test, we can detect both phoria and tropia.
Very nice. Okay, so what we do in cover and cover test, so we will be asking the patient to fixate on a particular target, and then we will be covering one eye. So, and that is we have covered one eye, then we will remove the cover and we will be assessing the movement of that eye. That will be cover uncover. So the movement of covered eye is seen in cover uncover. We will be covering one eye, we will be removing the cover, and we will be seeing the direction of that eye only. So it is cover and cover. Another is alternate cover test. Alternate cover test is to break the fusion. We alternatively cover both the eyes. Alternatively, we cover both the eyes, and then when the fusion is break, we will be seeing the movement. Like when the fusion is break, how our eyes are moving. It is moving inward direction. It is moving in the outward direction to fixate the target. So this is how we will check the phoria status. So if it is manifested deviation, if the misalignment or the turns are visible, then it is the tropia. But um, if it is not visible, then it is the phoria. And if there is no deviation, that is orthophoria. So hence in orthophoria condition, we will be checking the accommodative test, so as to rule out if there is any accommodative anomaly or not. But in case if the phoria is present, then we have to determine types of phoria, the direction of the movement after uncovering. So when the cover is removed, how your eye is behaving to refixate the target, this we will analyze. So if there is inward movement, let's suppose I covered the eye, I removed the cover, and my right eye moved in inward direction to refixate the target, that will be inward exophoria. How exophoria? Because when I covered, my eyes normal position was outward, and to refixate, then it came inward, so it is exophoria. If it is the inward movement, it is exophoria. If it is outward movement, when I have covered my eyes and my eyes rested in inward direction, and now to refixate the target, it is going outside, so it will be esophoria. If it is upward movement, then it is hypophoria. So if it is downward movement, it is hyperphoria. I hope it is clear. It is a bit tricky. If the eye is moving inward, then it was exophoria. If it is moving outward, it is esophoria. If it is moving upward, it is hypophoria, and if it is moving downward, it is hyperphoria. So to then what we do, now we know we have phoria present in the patient. Now we have to quantify it. Quantifying it is to measure. Now we are saying there is a deviation, but how much deviation? So that we calculate in prism diopters. So to quantify, we do prism alternative cover test or the Maddox rod test. So to quantify the amount of deviation or amount of phoria present in the eye, we do prism alternate cover test, or we do Maddox rod test to diagnose at distance and near. So we check the phoria status in both. We measure the phoria in both the distance, that is distance, and the near. Distance 6 meters, and near it is 33 centimeters. Okay.
Excuse me, ma'am.
Yeah.
Ma'am, is prism bar cover test or prism alternating cover test are different?
No, it is same only. So in prism alternative test, what we do is, while we are applying the prism in front of the eye, we are alternatively covering the eyes so as to neutralize the deviation. So in prism bar test, what you are saying, prism bar test, that is for tropia, where we don't alternatively cover the eye. So because the misalignment is visible. So in if the misalignment is present, we don't need to break the fusion. But as in PHORIA, we have to break the fusion. So in this, we do alternate cover test along with the prism. I hope it is clear.
Yes, ma'am. Thank you.
Can I interrupt in between?
Yeah, sure.
Uh, the eye which is gone up and coming down is hyperphoria, and the eye which is gone down and coming up is hypo. The small correction there. And
Uh,
prism bar cover test and the prism cover test is little different. When you're trying to do something with the prism, when you're trying to check tropia, that is the prism test. Prism bar, when you say bar, we usually see NFE, PFE by doing a bar test
mhm.
because this has a step prisms. So in
Yeah,
this step prisms, we want to see what is the capability or the amplitude of the this fusion.
deviation.
So that is what we are going to do. So usually cover test, if you see the ophthals usually use a single prisms, not bar prisms.
Bar
Okay.
prisms.
So that is the reason I don't know why we optometrists are using the bar. We have to use a single prisms. Bar is used to check the fusional amplitudes, not the the phoria or tropia to find it out.
Yeah, true. So basically, as you said in the correction for the upward movement and
I want to
down.
intervene in this comment. So, it is not like that we should not use prism bar. It is like, for example, a patient who is not cooperative, or you are dealing with a special population. In that condition, you do not have anything to do subjectively. In that way, how to measure the amplitude and the magnitude of the deviation. So for that, you definitely have to use prism bar to differentiate how much is the deviation is coming up. Okay.
Yeah, true.
Yeah, we
So
can use
basically,
both. It's not just the prisms or prism bar, but I'm telling you the prism bar is particularly used to check the amplitude of the fusional range.
Okay, I'm
Sir, with
really
due
sorry
respect,
to
I think
interrupt all of you.
we need to, yeah.
Can you all please let me complete? See, this is a presentation going on, and I think that there are a lot of students here. So first of all, let us conclude the presentation, and then we can have the discussion, if you all don't mind.
Sure, sure, definitely. Please go ahead, Nishtha.
okay,
Nishta,
okay,
please go ahead.
okay. Thank you. So, but here, as the correction you made, upward movement is hypo only, because when the eye is covered, if in normally it is going down, and when we are removing the cover, it is going in the upward direction to refixate it, then definitely phoria present is hypophoria only. And if we are hiding the if we are covering and it is in downward movement, if the downward movement we are seeing when the cover is removed, then definitely the resting phoria was the hyperphoria only. So it is mentioned correct, I guess. Rest we can go through again. So if exophoria present at distance, so we discussed like there is a condition, either the phoria will be present, either the phoria won't be present. If the phoria is present, then definitely there are more categories. So if exophoria present at distance, as we discussed, if exophoria is present, then definitely we have to do PFV, that is positive fusional vergence test. So in exophoria, it is controlled by the PFV, positive fusional vergence. Why? Because exophoria, a latent outward deviation of the eye. Exophoria was the a latent outward deviation of the eye. Eye tends to move outward when fusion is break. By PFV, base out prism. Uh, so basically the PFV, we use base out prism, which is a converging thing. So to measure something, then definitely we have to go against the deviation to analyze how much is the strength. So if eyes are going outward, we have to measure its strength, we will use the prism which will be against it. So we use base out prisms, as it produces convergence. To analyze the power of exophoria, we should apply PFV, that is base out prism. So PFV pulls the eyes inward to maintain binocular single vision. So we use the prisms. In PFV, we use the base out prism to maintain the binocular single vision, but exophoria is then measured. So in here, we evaluate the AC by A ratio and compare distance and near phoria. So if the distance phoria is greater than near phoria, so as we discussed, phorias are measured in both the distances, that is distance and near. So if distance phoria is greater than the near phoria, we can not only by only one criteria we describe it is a divergence excess, but there are multiple more um, criteria to define it as a divergence excess. So further in further slides we will be discussing all the criteria. Then second thing would be if the distance phoria is equal to the near phoria. So phoria is present for the distance as well as for the near. So in that case, we say it as basic exophoria. Then another criteria would be, or the possibility is, the near phoria is larger than the distance phoria. If the near phoria is larger than the distance, that will be convergence insufficiency. Then how we will be discussing it in detail. So in divergence excess associated with distance viewing then near viewing, most common symptoms include intermediate diplopia for distance, headaches, and eye strain. So in divergence excess, eyes are a bit more deviated towards the out, that is exo. So signs are intermediate to constant exo deviations for distance greater than near of more than 4 prism diopters. So here what we are going to say is intermediate to constant exo deviation. So for distance is greater than near for more than around 4 prism diopters. Low PFV break less than 10 prism diopters for distance. So whenever we are performing the PFV, the break will be less than 10 prism diopters for distance. Difficulty clearing plus lenses, as we all know, plus lenses are to relax the accommodation. So in this case, plus lens will be difficult, patient will be facing difficulty with BAF less than 8 CPM cycle per minute. So the normative data is for the phoria is distance, there should be one exophoria plus minus of standard deviation of 2 prisms, and near will be 3 exophoria, that will be 3 prism diopters. Then comes the basic exophoria associated with reading or other near tasks with near and distance activities. So in this, both the near and distance activity will be affected. Most common near point complaint includes eye strain, headache, and blurred vision. So its signs is equal amount of exophoria for distance as well as near. The receded NPC break. So as, I hope you all know how to do NPC. So a break will be analyzed less than in 6 centimeters with accommodative target. Reduced PFV break less than 10 prism diopters for distance and less than 15 prism diopters at near. Difficult clearing plus 2 DSPH with binocular accommodative facility less than 8 CPM. So the near point of convergence normative values are accommodative if we are using accommodative target. So break will be, it should be, the break should come at 2.5 centimeter with standard deviation of 2.5, and the recovery should be analyzed at around 4.5 centimeters, that is plus minus 3 standard deviation. And if we are using the pen light and red green glasses method, then the break should be 2.5 centimeters with the standard deviation of 4, and the recovery should be 4.5 with the standard deviation of 5. Then comes to the convergence insufficiency. So it is associated with reading or other near tasks. As the name suggests, convergence insufficiency, patient is converging, lack of patient is not converging to the limit which is necessary. So generally worse at the end of the day, if patient is complaining like at the end of the day my headache is boosted up and I feel a lot of strain, so it might be possible the patient is suffering from convergence insufficiency. Most common symptoms includes asthenopia, headache, and intermittent diplopia. So signs are greater exophoria for near than distance. So here the greater exophoria. So in near, usually our eyes are in iso, like to converge, they are together near. But here in this thing, greater exophoria for near than distance. So exophoria, like the divergence is more seen in case for near than the distance, like comparison to the distance for more than 2 prism diopters. So definitely the eyes are not converging to the up to the mark, so it is creating anomaly symptoms. So receded npc, in this case definitely in near point of whenever you will check the npc will be receded with accommodative target. So the range is greater than 6 centimeters. So the near point of convergence will be something back than 6 centimeters. And when checking break with pen light and red green filters greater than 12 centimeters. So in this case, reduced positive fusional vergence break will be less than 15 prism diopters, and the patient will be feeling difficulty clearing +2 DSPH with binocular accommodative facility, and this cycle would be less than 8 cycles per minute. So same the normative data as we discussed before. So if now till now we have discussed if they're the case of exophoria. So we discussed 3 things. See, divergence excess, basic exophoria, and convergence insufficiency are the cases or which we can take into account when we are observing exophoria. But if there is esophoria present at distance, then we have to check for the NFV. So to investigate esophoria, we have to go again to the against of the phoria present. So we will be using the NFV. NFV is the negative fusional vergence, which uses base in prism, which causes our divergence basically. So controlled by NFV, negative fusional vergence, esophoria is a latent inward deviation of the eye. Eye tends to move inward when fusion is broken by NFV base in prism, which produces divergence, and NFV pulls the eyes outwards to maintain binocular single vision. So if we have to calculate the AC by A ratio, and then the distance and near phoria is being calculated, and then we have to make some choices according to the resultant which we got. So if the distance phoria is greater than the near phoria, this possibility. If the distance phoria is equal to the near phoria, and near phoria is larger to the uh, near phoria. So in case here we are with divergence insufficiency. So in this case, distance phoria will be greater than the near phoria. Associated with distance viewing, the most common symptoms include intermittent diplopia for distance, headache, and eye strain. So divergence insufficiency is the condition where to fixate at a target, our eye is not diverging that much. There is some restrictions or the proper divergence is not present. So the sign is esophoria greater for distance. So in for distance viewing, definitely we need a proper diverging thing. But if we are observing a esophoria greater for distance than near, then definitely there is some divergence insufficiency. Then reduced NFV break less than 6 prism diopters for distance, difficulty clearing minus spherical lenses with binocular accommodative facility less than 8 cpm. Now if you would compare, before we were getting difficulty clearing plus lenses, but here we are in divergence insufficiency case, the patient will be feeling difficult in clearing minus lenses. So the stimulation of accommodation is bit difficult. So Now heading towards the basic esophoria associated with reading or other near tasks and with distance activities. The most common near point complaint includes eye strain, headaches, and blurred vision. Common symptoms associated with distance include blurred vision and diplopia when focusing at distance. So the sign is equal magnitude of esophoria at distance and near. Reduced NFV, break less than 6 prism diopter at distance and less than 10 prism diopters at near. Difficulty whenever we are performing binocular accommodative facility, -2 lenses, the patient will feel difficulty clearing the -2 spherical lens. Then comes the convergence excess. The patient is converging more as the demand. So in this case, it is associated with reading or other near task and generally worse at the end of the day. Most common symptoms include astinopia, headaches, and intermittent diplopia. So if the target is to see it here, the patient is converging more as the target is here. So the sign is esophoria greater at near than distance. So the phoria for the near is more than the distance by 3 prism diopters. Reduced NFV, that is negative fusional vergence, break less than 10 prism diopters. So when the base in prism is applied, then the break which will be observed will be less than 10 prism diopters at near. Difficulty with binocular accommodative facility in clearing -2 lenses, and high monocular estimation method MEM. So lag of accommodation greater than plus 1.525 diopters. If there is no phoria present, so now it's the case when there is no phoria present, so we have to investigate for the accommodative group of data, and then definitely we have three things which we will be getting: test probing ability to stimulate accommodation. So if we are evaluating the accommodation, so to keep the things clear at near, accommodation is a phenomena. So if that accommodation is not appropriate, whether it is less, whether it is more, or whether it is unstable, it will be creating problem. So if there is stimulation issue, accommodation are low, then it is accommodative insufficiency. If the required accommodation is not being stimulated, it will be causing accommodative insufficiency. The test proving ability to relax the accommodation are low. If there is a relaxing issue, if the patient is facing difficulty with plus lenses, then it will be accommodative excess. And the test proving ability to stimulate and relax accommodation, both facing difficulty in stimulating and relaxes in the accommodation, then it will be accommodative infacility. So accommodative insufficiency, difficulty with monocular accommodative facility less than 7 cycle per minute, and binocular it will be less than 8 cycle per minute, and with both plus minus to in the presence of NFD findings. So to make it a clear accommodative insufficiency case, only accommodative facility, we don't have to see only accommodative facility, but we even have to see the NFV findings also. So normal, we will be getting normal amplitude of accommodation, normal fusion versions. For diagnosis, all three criterias are mandatory. Accommodative excess. In case of accommodative excess, low monocular estimation method. So in MEM, I guess you all know how MEM works. So it is a static retinoscopy where we ask the patient to read what is on the MEM card, and we perform the retinoscopy. And then definitely, if the values are less than or equal to plano, whenever we are reading something, definitely we are using our accommodation. And if when to neutralize that accommodation, if the values are less than or equal to plano, it is telling us the lead of accommodation. Esophoria for near more than 3 prism diopters, and there is variable visual acuity findings, variable static retinoscopy, and subjective refraction. So whenever we are getting something very unstable visual acuity or unstable static retinoscopy finding, then we can assess this we can say it is as a accommodative access case. Then comes the accommodative infacility. So facing difficulty with monocular accommodative facility less than 7 cpm, or the BAF less than 8 cpm with both plus and minus lenses. In the presence of NFB findings, we will be observing normal amplitude of accommodation, normal fusional divergence amplitude, and all the criteria should be fulfilled to make it as a accommodative infacility slide. So take home messages: stepwise and steady wins the race. Stepwise evaluation helps unravel the components of NSBVA. Proper history tracking can be the biggest clue of binocular vision evaluation. So just by seeing 6/6, it is not ideal thing. We should take care of other parameters too to make the comment that your eyes are healthy. Here are the references, and thank you.
Thank you so much, ma'am, for such a clear and wonderfully delivered session. I'm sure all of us gained a lot from it. Now we'll move on to the Q&A. As I've already mentioned in the chat box, if anyone wants to ask a question, you can raise your hand and then I'll take your name and you can unmute yourself and ask directly to ma'am. But before we take those questions, I think us we have some questions in the chat box as well. So the first question is, ma'am, what about NRA and PRA test for making a diagnosis?
Yeah, definitely. See, these criteria has been taken from a band study done by the Rizwana, ma'am, and definitely NRA PRA values are very much essential to make a clear cut things for the accommodation. So NRA PRA is negative relative accommodation, and PRA is a positive relative accommodation. In NRA, we use plus lenses to evaluate the accommodative status, and in PRA we use minus lenses. So as minus lenses are to stimulate the accommodation, so in NRA we check if the patient is stimulating the accommodation normally or not, and in PRA it uses sorry in NRA we uses plus lenses, which is somehow relaxing the accommodation. So whether to check the patient is uh, relaxing the accommodation, so it is for NRA, and in PRA we use negative lenses so as to check the stimulation of the accommodation. I hope it's clear.
Yes, ma'am. And we have another question in the chat box itself. How do we differentiate between NSBV with computer vision syndrome?
See, it is a different topic now. So, computer vision syndrome, there are many other factors too, in which we have to account the screen time of the patient, and the posture, how the ergonomics of the patients is, the visual demands, and all. So, it is the different vast topic again.
Okay, okay, all right. So, attendees, if you want to ask any question, please raise your hand. I think we should wait for a minute. I guess the okay, okay. We have our first question. Soreen Pal has raised a hand. So, Soreen, go ahead with the question.
Hi, ma'am. Good morning.
Hi, good morning, sir. How are you?
I'm doing good. My question is, how long we should cover? Like, what is the time duration, or there is nothing like that?
See, definitely. Why we use alternative cover test is to break the fusion. There should be a few seconds we should wait to break the accommodation, and then we should remove the cover.
Okay, so any is there any ideal time or any gold standard time, like, or is it's all case specific?
I guess it's case specific.
Yeah. Okay. Okay, thank you, ma'am.
Yes, sir.
Okay, I think we have another question in the chat box. Yeah, the question is, when would you recommend doing a prolonged cover test?
So when to do a prolonged cover test. Okay. So in case where we find the fusional thing is very strong, our fusional in binocular vision, where when the fusional range is very strong, then definitely we should be using the prolonged.
Okay, all right. I think Nikhil Rao wants to ask something. Nikhil has raised a hand. Can you go ahead, Nikhil?
Yeah, hi, it was a nice presentation.
Right, thank you.
Uh, what about the difference of accommodative insufficiency and accommodative infacility? You had mentioned in your this
Okay.
slide.
Okay.
Nothing mentioned about the amplitude. You said it as amplitude is
Okay.
normal.
So basically,
In
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 accommodative.
accommodative insufficiency and in facility.
Okay, so basically, when the patient is complaining, like uh, everything is fine, and after prolonged work time, if the patient is feeling symptoms like in morning everything is fine, but in evening I am feeling so much of eye strain, headache, and fatigue. So somehow in that case, uh, when the in facility, basically the stimulation and relaxation both are the problem, but in insufficiency basically we feel the difficulty in relaxing the accommodation, sorry, stimulating the accommodation. Accommodative insufficiency, the required accommodation is lacking. So basically the patient would be feeling more problem in minus lenses, stimulation issue. But in facility, both the lenses plus and minus, the patient will be telling the thing, difficulty whenever you
So
will be doing. Yeah,
can we go back to your previous slide, like which is explaining about the accommodation?
great, let me share it. Hmm.
So here it is mentioned normal amplitude of accommodation, insufficiency, and the infacility. There is no difference between the infacility and
Okay,
insufficiency.
so yeah, here
It
it
says both the
is
same.
not both. Yeah, it is only in minus lenses. So in accommodative in
No, no, no.
facility, in
In the amplitude, normal amplitude of accommodation, in insufficiency as well in infacility. The second point.
okay,
Yeah.
yeah, yeah, definitely it will
So
be
the
hampered.
accommodation amplitude will be less,
Hampered.
no? Mhm.
Yeah, hampered amplitude of accommodation here. Yeah.
I think that summarized the question. But before I move on to the next question, I would like to tell something to the attendees. Kindly keep your question a little bit concise. That way, a lot of people can get the chance to ask their questions. Now, moving on, there is another question. We have how to approach a residual squint post-operative patients for vergence difficulties.
So, wait,
Do
let
you
me
want me to
open the
repeat
chat.
it? Do you
Yeah,
want?
wait, let me. I'm opening the chat box.
Okay, all right, all right.
Where is the question? I wish there are so many questions in the chat box.
Anish asked this question. It is the last third question.
See, how to approach residual squint post-operative patient for vergence difficulty. It is not included in our thing. So the today's presentation was more based on the NSBVD. So it is quite out of the box. We will be discussing it later. Next is, ma'am, can you explain the role of AC by A ratio in the diagnosis of NSBVA? Definitely, AC by ratio plays a major role in NSBVA. So, what is AC by A? Definitely, it is the accommodative convergence by accommodation ratio. So, to diagnose, as we discussed in where how to calculate first the AC by ratio. There are two methods to calculate the AC by ratio, that is the calculative method and the gradient method. So in calculated method, the PHORIA is being checked for distance and near, and the IPD is taken into account, and then the AC by ratio is being calculated. So normal range of AC by ratio is the 4:1. If there is the higher AC by A ratio, then definitely your more ESO of thing, esophoria will be evaluated. And if it is low AC by A ratio, then definitely the exophoria kind of thing will be the more issue. Then is, ma'am, is if there is a phoria and in dry retinoscopy there is plus 0.5 and plus, what should I do? Move for orthoptic examination for exercise or do detailed cycloreflection first in it? See, Pradyuman. Yeah. If there is phoria in and in dry retinoscopy there is plus 0.5 and plus, definitely then the age of the patient will be mattering to do a cycloplegic refraction even first in adolescent. Okay, exercise. So what I would recommend is to definitely do a cyclorefraction, because sometimes latent hyperopia also comes into play. So a cyclorefraction would be making it more clear that why it is coming. So to move forward with the cyclorefraction.
I think that is the end of the
That's
questions. I think we do not have any more attendees with questions. So thank you so much, ma'am, for explaining all the doubts in with such clarity.
Thank you so much.
I'm sure
Hello,
the is there anyone else?
hello.
Yeah, Adnan, please speak.
अब सबके डाउट हो गए तो निशा मैम, फर्स्ट ऑफ ऑल जो प्रेजेंटेशन भी आपने, ये मतलब बहुत फैबुलस थी। स्पेसिफिकली आपने जो आज का टाइम निकाला है, जो करेज इसमें लगा, एंड जितने जो आपने एफर्ट्स दिए, उसके लिए थैंक यू।
Thank you so much, Adnan. Thank you so much for taking my efforts into account. And I thank Neuroptech to give me the opportunity to present, because I work as an assistant manager in biotech, and before I was in IIMT. So before I was more into students, but now my population are more of the sales executive and a bit far of the teaching. But I am now loving it. So thank you so much.
मैम एंड
Thank
मैम एक बेसिक क्वेश्चन है, इफ वो आज हो पाए देन इट्स ओके, नहीं तो अगर वो हम आगे सेशन में भी रख सकते हैं। लाइक जैसे माइस्थेनिया ग्रेविस है, ऑटो इम्यून डिसऑर्डर है, अगर वो किसी तरह से नॉन स्ट्रैबिस्मिक बाइनोक्युलर विजन एनोमली को प्रमोट कर रहा है, क्या वो एक हिडन कॉज हो सकता है? ये मेरा क्वेश्चन था।
Definitely. See, in Myasthenia gravis, many more factors are included, and then truly we can't count it into a NSBVD case, because anatomical changes comes into play again.
यस
But
मैम।
in NSBVD, more of it is the more anatomical things are normal, refraction is normal, visual acuity is normal. So it will be different. But rest we will be taking into further discussion.
यस यस मैम, थैंक यू मैम। मैम एंड लाइक जैसे जो असेसमेंट का तरीका है नॉन स्ट्रैबिस्मिक बाइनोक्युलर विजन का, उसमें कई जनरल कंसिडरेशंस होते हैं, लाइक वो स्टेप वाइज प्रोसीजर्स है कि हमें सबसे पहले मैग्नीट्यूड एंड डायरेक्शन को एसेस करना होता है,
जी,
राइट? तो मैम उसमें लाइक जो मैंने पढ़ा है लाइक वोन ग्रेव मेथड, न्यू थेरिंगटन मेथड भी है एंड फिक्सेशन डिस्पैरिटी मेथड भी है।
Method
सो
B.
मैम जो फिक्सेशन डिस्पैरिटी मेथड है वो एक लौता ऐसा मेथड है मैम जो बाइनोकुलर विजन में एसोसिएटेड कंडीशन में वो वर्क कर रहा है। तो ये क्या उतना ज्यादा रिलायबल और उतना ज्यादा अच्छा है इफ वो एसोसिएटेड कंडीशन में वर्क कर रहा है?
Definitely to check the fixation disparity, then definitely it should be associated. But for to make it more clear, then there are many dissociative tests also. This like Tharrington also. So there are we can combine the things and then come into some specific thing.
श्योर मैम।
Yeah.
Okay, all right. I think we are moving towards the end of the session now. Attendees, I think you all can see there is a QR code on your screen. Please scan it for your certificate. You can take the screenshot now and you can fill in the details later. I'm taking a 30-second pause so that no one misses it. I think you all must have taken the screenshot by now. So, as we move to the end of the session, I would like to thank you once again, ma'am, for such an informative session and for answering all the doubts beautifully. And thank you to all the attendees for joining us this Sunday morning. The QR, I think you all have taken the screenshot of it. This is Shazia Shabir, your moderator for today's session, signing off. Have a wonderful day, everyone.
Thank you so much. Thank you, everyone.